Assalamu alaikum. I'm Professor Dr. Hayder Mubarak. This is a presentation to practical aspects of the oral cavity and palate. The oral cavity, as is shown in this mid-sagittal section, is limited anteriorly by the oral fissure, which is the opening between the upper and lower lip, while the posterior limit of the oral cavity is the oropharyngeal isthmus, which is the junction between the mouth and oral cavity anteriorly and the pharynx posteriorly. Actually, this part of the pharynx behind the mouth is called oropharynx, and the oropharyngeal isthmus is the region between the mouth or oral cavity anteriorly and the oropharynx part of pharynx posteriorly. You can see that this oropharyngeal isthmus showing the palatine tonsil. This tonsil lie in a foci that is limited anteriorly by palatoglossal fold and posteriorly by palatopharyngeal fold. And this palatopharyngeal fold is the fold that representing the oropharyngeal isthmus. Actually, the oral cavity has two parts. The first part, which is located to the outside of the teeth, outside to the gum, and outside to the alveolar processes inside the gum that carries the teeth, whether these are alveolar processes are of the maxilla for the upper teeth or mandible for the lower teeth. So the space to the outside of the teeth, to the outside of the gum, and to the outside of the alveolar processes inside the gum of the maxilla or mandible, this part is called vestibule of the mouth. This vestibule of the mouth is limited from outside by the cheeks on the right and left side and by the lips anteriorly, the upper and lower lip. The second part of the oral cavity is called oral cavity proper, which is the part lying to the inside of the teeth, to the inside of the gum, and to the inside of the alveolar processes of maxilla or mandible. This part, the oral cavity, is connected with the vestibule by a small region that is lying behind the third molar tooth, which is the last molar tooth. Actually, the oral cavity proper has a roof, floor, and lateral walls. The roof of the oral cavity proper is formed by the palate. And you know that most of the anterior part of the palate is the hard palate, which is the bony palate, that is formed in its anterior two-thirds by the palatine processes of maxilla and its posterior one-third by the horizontal plates of palatine bone. The most posterior part of the roof, which is the palate, is the soft palate, which is actually a muscular structure, sometimes called the uvula, containing a fibrous tissue called palatine aponeurosis. The soft palate, which is the uvula, has an important function during swallowing because it may elevate up and press down. When it elevates up, as this figure shows, when the soft palate, the uvula, elevates up, it closes the upper limit of the oropharynx from the space behind the nose, which is called nasopharynx. And so the swallowed bulk of food will pass downward and is prevented from passing up into the nasopharynx because the soft palate elevated to close the junction of the nasopharynx with the oropharynx. And also the soft palate could be depressed down to close the oropharyngeal isthmus during chewing and swallowing. Regarding the floor of the oral cavity proper, it is formed of many layers of muscles. Starting from the most superficial is the mylohyoid muscle, which acts as a diaphragm closing the floor of the mouth. Deeper to mylohyoid is a geniohyoid muscle. The name of geniohyoid muscle indicates that it is attached to the hyoid bone and also attached to the genial tubercle on the inner surface of the mandible below the incisor teeth. Here we have a genial tubercle giving attachment to genioglossus muscle and so geniohyoid muscle, and so it is called geniohyoid because it extends from the genial tubercle to the hyoid bone. Deeper to geniohyoid muscle is the muscle of the tongue, which is the bulkiest muscle of the tongue. And this region of the floor of the mouth contain, in addition to these three muscles, also salivary glands and the submandibular and sublingual salivary glands. The lateral wall of the oral cavity is formed by the cheek. The cheek structurally is formed by buccinator muscle, which is one of the muscles of facial expression, Buccinator is lined from inside by the oral mucosa, while buccinator is covered from outside by skin and superficial fascia, and here the superficial fascia contain fat that is called buccal pad of fat. We must say that the palate with a soft or hard palate is covered superiorly by a mucosa which is of respiratory mucosa, mucosa of the nasal cavity, while the palate is lined from inside by mucosa of the mouth. And we can see that the undersurface of the tongue is connected to the floor of the mouth and the midline by a fold of mucosa called the frenulum. Regarding the anatomy of the tongue tongue is a muscular organ. It contains two groups of muscles. One of them is called intrinsic muscles and the other is called extrinsic muscles. The name intrinsic muscle indicates that these muscles originating and inserting inside the tongue. They include a superior and inferior longitudinal muscles, transverse muscles, and vertical intrinsic muscles. These intrinsic muscles, when they contract, they are functioning to change the shape of the tongue and the size of the tongue. The other group of muscles of the tongue are the extrinsic muscles of the tongue, and as the name indicates, they originate outside the tongue but are inserting into the tongue. The bulkiest extrinsic muscle is genioglossus muscle. Genioglossus originates from the genial tubercle on the inner surface of the mandible below the incisor teeth and inserted into the tongue. But this genioglossus muscle is very big muscle. It is fan-shaped muscle. Its insertion not only to the side of the tongue but also extends to the hyoid bone. In addition to genioglossus muscle, which is the bulkiest muscle of the extrinsic group of the tongue, we have other group of muscles. For example, styloglossus muscle that is originating from the styloid process inserted into the side of the tongue. Hyoglossus muscle that is originating from the hyoid bone inserting into the side of the tongue. And palate-glossus muscle, which is originating from the soft palate, actually originating from the fibrous tissue of the soft palate, which is called palatine aponeurosis, but palate-glossus is inserted into the side of the tongue. All the extrinsic muscles, when they are contract, they are functioning to move the whole tongue in comparison to the function of the intrinsic muscles. Intrinsic muscles change the shape and size of the tongue, but not moving all the tongue. But extrinsic muscles moving all the tongue, and you can see that the function of these muscles could be known from the direction of the fibers. For example, palate-glossus muscle, from the direction of it, you can know that it could elevate the tongue, especially the posterior part of the tongue. While hyoglossus muscle, from its direction, it depresses the tongue and pull it backward, retraction of the tongue. Styloglossus muscle also, it could elevate the tongue and pull it backward, retraction. Regarding the function of the genioglossus is very big, so in order to describe its function, we must describe the function of the superior fibers, middle fibers, and inferior fiber. The superior fibers pull the interior part of the tongue downward, the middle fiber depress the tongue, and the posterior fiber protrude the tongue. All extrinsic and intrinsic muscles of the tongue are supplied by the hypoglossal nerve, which is the 12th cranial nerve, except palate-glossus muscle, which is supplied by the vagal nerve, that is the 10th cranial nerve. And actually, because palate-glossus is a muscle that is considered a muscle of the tongue and also a muscle of the soft palate, and therefore it is supplied by the vagus nerve, which is the nerve supplying all muscles of the soft palate. Regarding innervation to the mucosa of the tongue, in order to describe innervation to the mucosa of the tongue, we must divide the tongue into a posterior 1/3 of the tongue, which is called root of the tongue, and anterior 2/3 of the tongue, which is called body of the tongue. You can see that there is a V-shaped sulcus, which is called sulcus terminalis, separating the posterior 1/3, the root of the tongue, from the anterior 2/3, which is the body of the tongue. This sulcus terminalis, the V-shaped sulcus, its apex is called foramen cecum. So, regarding the mucosal nerve supply to the tongue, the anterior 2/3 of the tongue, which is body of the tongue anterior to the sulcus terminalis, is supplied in regard to general sensation, which is pain, temperature, and touch, by the lingual branch of mandibular nerve, while this anterior 2/3 of the tongue is supplied by taste sensation from the chorda tympani branch of facial nerve. Actually, the chorda tympani is a branch from the facial nerve. It originates from the facial nerve inside the bone of temporal bone, inside the patellus temporal bone. And this chorda tympani nerve then run in the middle ear cavity and then exit out of the temporal bone and connected with the lingual nerve in the infratemporal fossa, as we had discussed this in the infratemporal fossa. Therefore, mucosal nerve supply to the tongue and the anterior two-thirds of it, which is the body of the tongue, anterior to sulcus terminalis, receives this region, the body of the tongue, the anterior two-thirds receives general sensation from the lingual branch of trigeminal nerve, of mandibular nerve, which is branch of trigeminal nerve, and taste sensation from the chorda tympani branch of facial nerve. The posterior one-third of the tongue receives general sensation and taste sensation from the glossopharyngeal nerve, which is the nanocranial nerve. The most posterior part of the tongue, behind the root, has general and taste sensation from the internal laryngeal nerve, which is a branch from vagus nerve. Blood supply to the tongue is via the lingual artery, which is a branch of the external carotid artery, and tonsillar branch of facial artery. Venous drainage of the tongue is to the lingual vein. And there is a condition which is very important in regard to the clinical aspects of the tongue, which is called tongue tie. We had said on this figure that the undersurface of the tongue in the midline is connected to the floor of the mouth by a fold in the midline called the frenulum. Sometimes this fold, the frenulum, is short, and it limits the movement of the tongue because it is short. And this condition is called the tongue tie. Actually, during childhood, it will make a difficulty for the baby to have breastfeeding, because the tongue will not be able of sucking during breastfeeding, because the frenulum is short and it limits the movement of the tongue. And not only that, also when the child will grow up, the tongue articulates the sound to produce words. The tongue is very important for speech. It articulates the sounds to produce words, and therefore this child with a tongue tie will have a difficulty in speech, and therefore they must have an operation to cut this frenulum that is short and make it long. Regarding innervation, the sensory innervation to the oral cavity, the sensory innervation to the oral cavity in general is from the trigeminal nerve, while the hard palate is innervated by the greater palatine and nasopalatine branches of maxillary nerve. The soft palate sensory innervation is from the lesser palatine branch of maxillary nerve. The floor of the oral cavity receives sensory innervation from the lingual nerve, which is, as you know, a branch from mandibular nerve, branch of trigeminal nerve. The cheeks are supplied by the buccal branch of trigeminal nerve with general sensation. That's all about this subject. Thank you very much.